We have Dr. George Githuka in the building. Welcome to the show.
Thank you.
And we're talking matters malaria. And just before we got on during the break, I was saying how, well, growing up, I remember very huge campaigns around malaria and the prevention and everything there was to know. And even in schools, we'd learn a lot about it. Somehow, along the way, it stopped being very loud, and then probably we focused on other things. We had the cancers of the day where we talk about, lifestyle diseases. But malaria is still one of the very most important conversations that we should be having today. And I'm glad that we're doing it today on the show.
Yes.
Before we get into it, kindly introduce yourself to the people.
So I'm Dr. Githuka George, the head of the Division of National Malaria Program at the Ministry of Health.
Great. What are the statistics like? Where are we at when it comes to malaria?
Malaria is still a disease of major public health concern in the country. It's the second leading reason why people visit a hospital outpatient facility, I think, after diseases of the respiratory system that are very common. The second one is malaria. Malaria is not evenly distributed within the country. We have some areas that are high burden, like the counties around Lake Victoria. Some 8 counties we call lake endemic counties, where about 1 in 5 people will have malaria at any given time. We have a prevalence of 19%, though there has been progressive decline from 27% in 2015. We have also the counties around the Indian Ocean, what we call the coast endemic counties, where the prevalence is around 8%. In those 2 areas, around Lake Victoria and around Indian Ocean, malaria transmission occurs throughout the year. In other areas, we have like what we call the highland epidemic-prone regions of the country. That is where the transmission occurs during the rainy seasons. And in the northern part of the country, what we call seasonal transmission is when there's a lot of rain. However, in the central part of the country, Nairobi, the central region, the lower eastern region of the country, we call them low-risk malaria regions, where the prevalence is less than 1%. There's not much malaria transmission happening. So malaria is a big concern in the rest of the country, apart from the low transmission regions.
Okay. And thank you for clearing that up, because I was busy having a face down with somebody yesterday who said that Nairobi is not, a highly transmission town. And I was like, what? I don't think this, I don't, we sleep under nets. It's been the thing that we've known all this while. But then when you look at, if you're going to Mombasa, then you'll be told to pop a pill before you go there. If you're going to Kisumu, you'll be told to pop a pill. What does that pill do?
There are various ways that you can protect yourself against malaria, especially, as you say, if you're traveling to regions where there is a lot of transmission.
Yes.
Number 1 is, of course, to sleep under a mosquito net once you go there. Number 2 is to ensure you can also have mosquito repellents that you can apply on the exposed part of your bodies. And also, as you've said, there are medication that you can take that can protect you against malaria. Though that is not commonly done right now. Not most people will do that. However, I think one of the most important things with malaria is also having, if you've traveled to those regions, or if you have any signs of malaria, if you have a fever, joint aches, headaches, feeling weak. Number 1, it's not good to self-treat yourself. Don't go into a pharmacy and say maybe you have malaria and you'd like to be treated. Those symptoms are similar to like a common cold, a flu, many other infections. And when you assume it's a flu and it could be malaria, then you might get into severe malaria. Uncomplicated malaria is very easy to treat. If you develop those signs like fever, what I've said, and you go to a health facility within 24 hours and you're appropriately tested and diagnosed, and in case you're found with malaria, you'll only take a 3-day drug course, and that should be able to treat you against malaria. If you delay much further, you might get into what we call severe malaria. What people will say like cerebral malaria. You might go into severe anemia, your blood levels go really low. Some organs may get damaged by the parasites, and that will make the management of malaria very difficult. And it could lead to death. It could lead even to permanent disability. If you have like cerebral malaria, you might never fully recover from it. And it's also quite expensive to be able to treat severe malaria. As with any other infection, if you had thought you had malaria and you took anti-malaria drugs and you had another infection, the longer it takes for you to get properly diagnosed and treated, the more complicated that infection happens. So the most important thing is go to a health facility as soon as possible when you have those signs. The signs also similar to like COVID. You know, those exact same signs. And a lot of people will fear going from a health facility, especially earlier on in the pandemic, fearing you could be diagnosed with COVID. But anything that is diagnosed early, especially infectious diseases, and managed earlier, it's always have better outcomes.
Okay, so the earlier you go, 24 hours would be best. If you go later, then the effects of that could be worse because of the amount of infection in your body at that point.
Yes.
Let's talk about pregnant mothers and the kind of protection they need for themselves and even for the unborn child.
Pregnant mothers and children under 1 year of age are the most vulnerable to the adverse effects of malaria. Malaria infection during pregnancy is a leading cause of loss of that pregnancy, either early or late. You know, having a premature delivery, having a child with a low birth weight, and even maternal death. As I said earlier on, malaria leads, those parasites feed on our red blood cells. So we get anemia, our blood levels go low. And any mother, when they're delivering, there'll be some bit of bleeding. So if the blood levels are already low because of malaria, then the chances of, you know, maternal mortality or maternal death due to that bleeding are much higher. And so the pregnant mothers, especially those ones in those endemic regions, the lake endemic, around Lake Victoria, the coast endemic, and even some other parts of the country where there's transmission of malaria, we advise them to go to antenatal clinic early, as with all the other mothers. When they go there, they will get a free mosquito net. They will start receiving a drug that is able to protect them against malaria. The drug we used to take a long time ago to treat malaria called Fansida. They take it monthly, you know, just before the end of the first trimester to time of delivery. They take Fansida on a monthly basis. It's directly observed. They're given by the healthcare worker and they take. It protects them against malaria. And, you know, it also keeps, it ensures that, you know, even if, of course, they will have been diagnosed and found not to have malaria, but even if they have any malaria, then, you know, somehow it keeps the parasite at bay. The pregnant mothers also, when they deliver and they bring their children to the child welfare clinics, they're also given a mosquito net for the child. Because again, children less than 1 year are more likely to get, you know, severe complications from malaria infection. So those two populations, pregnant women, children less than 1 year, are the most vulnerable, and that's where we focus our prevention interventions too. But it's not to say that everyone else in the population is not vulnerable, and that's why the insistence on seeking treatment early.
When you say they're given mosquito nets, this is for free, and for the medicine as well, this is for free, or do they pay an extra amount of money for these things?
In the coasts and lake endemic regions, and where some other facilities was given, it's free. Even the drug, the Fansida, is free. And even the mosquito net for the child is free. Just to add another point, again, in 27 counties, which are the endemic counties, the epidemic prone, and some sub-counties that show seasonal transmission, we normally do distribute free mosquito nets every 3 years. The lifespan of a mosquito net by there is 3 years. After 3 years, the insecticide in it is no longer effective. And we found that, you know, there could be general wear and tear of the mosquito net beyond 3 years that is not able to provide adequate protection. So, for example, like this year, we are distributing, you know, 15.7 million nets. We've already distributed 10 million, remaining around 6 million nets in those counties where we target to give at least every 2 people 1 mosquito net. And that happens every 3 years. And it happens at the community level. So we give all the households within the selected counties and sub-counties. Now, on top of that is any mother within those regions, again, as I said, if they come to a facility, they'll get that additional mosquito net for themselves. And once the baby is born, they'll get another mosquito net.
Oh, wow. I think that's pretty impressive. Very impressive. So they have a question here. Hello, Mikali. Good morning. I got misdiagnosed with malaria a lot of times because they are busy. I don't know, the conditions mimic other diseases. Is misdiagnosis a missing link?
Not really. Malaria is diagnosed in 2 ways. First, we have what we call rapid diagnostic test kits. You know, a kit, like, you know, like a pregnancy kit or like the kit used to test for HIV.
Yes.
That you have a blood sample taken and it's able to detect whether you have malaria parasites within in your blood. It's a very accurate test. If it tells you have malaria, you have malaria. If it tells you don't, then you don't have malaria. Although sometimes if we still strongly suspect that you could be having malaria, we might treat you. The second way is using a microscope, by a trained laboratory technologist or technician, where they're able to actually see the parasites in your blood when they bleed you and put your blood on a slide. Normally what we'll say, if the chance of misdiagnosis is where you are not tested.
Okay.
But whenever you get tested, that's what I was saying, whenever you get tested, you're found to have malaria, you're put on treatment. If it is not malaria, then you are subjected to further tests to find out what else could it be. But people will walk into a pharmacy and say, I have malaria, could you give me medication? Or in some instances, even when you go to a facility, which is rare, a health worker might decide to treat you, for malaria based on your history. But misdiagnosis is not a missing link. The tests that are there, both the rapid diagnostic test kits and the microscopes, are pretty accurate.
It's clear that the government is doing a lot in terms of helping to curb malaria. But what are some of the challenges? Why are we not getting to, the point where we are all striving at, where it's a no or low, very zero, close to no malaria in our communities?
Number one, there are various ways of protecting ourselves against malaria.
Yeah.
Like we've really dwelt a lot on mosquito nets. We also do indoor residual spraying.
What is that?
Where we spray insecticides that are safe within the structures where people live in. And this normally we do them in two counties, in Migori and Homa Bay counties. Mosquito, the mosquito that spreads malaria normally will bite at night and inside the house.
Yes.
So, or even in the evenings around the house. So maybe from around 6 o'clock even to about 7 o'clock, 6 p.m. to around 7 p.m. So like indoor residual spraying will be able, once mosquitoes enter the house, they rest on the walls. So if they have an insecticide, then that insecticide should be able to kill those mosquitoes and they don't survive. The other way of protecting ourselves against malaria is doing environmental management, ensuring that the environment around the house where mosquitoes breed is managed. There's something we call larva source management. The mosquitoes lay their eggs in pools of water. You can be able to clear this. In the lake endemic regions, we are doing spraying of, again, safe larvicides, drugs that kill the mosquito larva. They don't kill anything else apart from that. They don't affect the quality of the water. And that is also a way of reducing the mosquito population around there. Another exciting intervention that is being implemented, again, as a pilot within the 8 lake endemic counties is a malaria vaccine. There is a malaria vaccine that is being given to children from the age of 6 months. It's a 4-dose vaccine. They get their first dose at 6 months, the second dose at 7, their third dose at 9 months, and their last dose at 24 months, where they're 2 years old. And that is an additional arsenal that should be able to reduce the burden of malaria within our country. And if we see that it is working well in those lake endemic counties, then we'll be able to scale up this vaccine, to the rest of the country and make it part of the routine vaccines. Right now, we are doing it as a pilot. I think the most important thing also to say is that there is no one way that can protect us against malaria. So all combinations of these interventions have to be put in. Like the mothers, we are giving their children vaccines in Nyanza. We are telling them, or in the lake endemic region, we tell them, even your child develops fever or any of these symptoms, don't say that the child has a vaccine, so they can be having malaria. The vaccine is not 100% effective. Don't say the child has a vaccine, they won't sleep under a mosquito net, or you won't put other measures that are supposed to be that protects the child against malaria. But together with all these concerted efforts, then the burden, it's been gradually reducing. As you say, a long time ago, we used to hear more about malaria because it was actually more prevalent. But with effective interventions, it has reduced. But the last part of trying to eliminate a disease is the most difficult part.
That is true.
Because each and every case that comes, you feel like you've taken a step back. But we are making progress towards eliminating malaria in the country.
Okay. So when that works, when the vaccine works in these regions that we are already trying the pilots, then that means that everybody else, with the children, or will we get as adults, or maybe the children that we will be having, will it go a certain age, or will it be for everybody else? That will be open for them to get it?
The vaccine, as is right now, is not for everybody else. It's for those children. I think children who are 6 months to 2 years, they get their first dose at 6 months. The scientists are yet to develop a vaccine that would be suitable to other age groups, older children or even adults. But you realize even majority of the vaccines that we have, that we use, we normally start with children so that the protection can start, at a very young age. But it's not to say that there can't be vaccines for adults, but they haven't been developed yet.
Okay, and we're looking forward to that.
Same.
And maybe your parting shot before we let you go, what would be the message to Kenyans today, even as we all try to put in the work to make sure that we have a malaria-free country, or probably the world as well?
There's a campaign that was launched by the president last year, I think on 31st October 2020, that said zero malaria starts with me. It means you take the responsibility to protect yourself against malaria. You sleep under mosquito net. We say we give a lot of mosquito nets. Sometimes when we visit homes, we find they're not being used, or they're being used for other purposes. You find people have been sick at home with these signs and symptoms of malaria. They don't seek care. So basically, zero malaria starts with you. Zero malaria starts with me. If I take full responsibility and I protect myself and my family and the children, then we'll make a lot of progress towards the fight against malaria.
Absolutely. Thank you so much, Dr. Ari, for gracing our studios and reminding us the basics, that it's just because we've not been seeing a lot of that happen that we need to protect ourselves and even take care of our people who are in those particular regions that highly infectious when it comes to malaria. Asante sana.
Asante.
Great. So we're going to take a very short commercial break. We will be right back. So do not go too far. Remember to talk to us, 111 444 111. That is our SMS line. Send in all your questions. Switch TV KE on Instagram, Switch TV Kenya on Facebook. We will be right back after this break.